Thank you so much, sir. Thank you for having me as part of your course, and it's nice to follow, sir. There's a lot of preamble already given to this topic on how to manage the bubbles, and I'll try to add a little bit more about keratoplasty. So obviously, we have two major options when you have advanced keratoconus, whether to do a DALK or PK, and when you're doing a DALK, whether you would go for a big bubble or a manual dissection. So this is a patient with a significant amount of apical scarring. Previous contact lens wearer, now not comfortable with the scleral contact lens, and wants to undergo a DALK procedure. In all these patients, we do an anterior segment OCT, and as you can see here, this is patient is just an apical scar. There is no hydrops, and the DM is very much intact. There is a very little gap between the scar and the DM. These are patients who are very much amenable for a big bubble procedure, and after using your initial trephination, some surgeons directly like to go in with the DALK. I like to remove the anterior lamella and then go ahead with the big bubble. Generally, tips to achieve the big bubble is to ensure that you go paracentral. It doesn't have to be very deep, but once we reach the paracentral area, slightly dip down, you will feel an initial resistance, and once you see that resistance, you know that you are going to achieve that big bubble, because the bubble then percolates down, it starts spreading, and then it goes all the way to the periphery. There are two things which I'd like to describe here. If the bubble does not go all the way to the periphery, then you actually end up having a smaller bubble in the center, which ideally you can put in some viscoelastic and enlarge it. This is just that bolus of orogel or cohesive viscoelastic which I put on top, and then I'm ensuring that there are no additions. Now, since this was a big bubble which has gone right up to the trephination margins, I'm able to do this directly with the spatula. But in case it has not gone on, you could even expand it by injecting viscoelastic into the space, so that those additions between the posterior stroma and the DM are separated, and you can easily go ahead just with your DALK scissor and go ahead and cut it and remove it very easily. In case you get a type 2 bubble, something which I wanted to add was, very often in these type 2 bubbles, fortunately they're not very common, but they tend to expand beyond your trephination margin, and you have a loose redundant DM in those cases. Happens more with some of the dystrophy patients than in keratoconus, but still in these patients, once you're finished with your DALK procedure, you do well to fill the anterior chamber with air bubble so that it opposes again. Otherwise, very often you'll have this hanging DM and you have a double anterior chamber the next day when you have a type 2 bubble, and then you can go ahead with the procedure. Most of these patients have a pristine interface and do extremely well, and you can see that the ASOCT is also fairly uniform. There's no interface haze. Now, this is a patient who has had a post hydrops, and there is a post hydrops scar, and you can see in this ASOCT, as opposed to the patient who had just the apical scarring, this is an eye where the posterior layer DM has been disrupted. Now, once you've waited a sufficient period for this to scar down, usually this does not extend. But again, attempting a big bubble would not be a good idea in these patients, and generally what is recommended is a layer by layer dissection. Now, initially getting a good trephination with a vacuum or a manual trephine is important. Using a vacuum just gives you that extra level of comfort in terms of reaching a particular depth, and then you can deepen it, make the groove as deep as possible. Now, there are two ways you can approach. Either you can go on deepening it all around the periphery and then make it sufficiently deep and then remove it in a single layer. The only challenge is the visibility sometimes reduces when you go to the other side. So this is a technique which I prefer, where I generally, the anterior first layer can be removed directly even over the central cornea still, because there is some thickness left. But once you go on to the next layers, now this is just a little bit of dissection going beyond the trephination margin, because in these advanced cones, you can tuck in your graft a little bit, and the suturing, when it goes into that groove, the graft nicely tucks in, and then you don't have any malapposition. This is something which I prefer to do. So in the central area, it is thinner, but the peripheral area is thicker in these corneas. And ideally, you want to have a very smooth, uniform bed rather than having an uneven bed. So the dissection should be carried along all around the periphery, and the central area is usually not dissected till the very end. So basically, we are just concentrically removing circles of tissue around the central thin area, whereas we are leaving the central thin area over the area of hydrops, which is possibly only around 200 microns left intact. And then in the very end, as you would see here, once you have reached a very close to the predesmase, it peels off very easily without even dissection. It will peel off, and in this dissection all you're doing is just separating those fibers. You're not really dissecting, and it is very, very smooth. And once you've reached that particular plane, you can go ahead and suture. Now, the important thing to discuss here is, it's you would, and I'm just sure won't run through this video in detail, but it's just to show that this technique can be repeatable, and you can do this any number of times and keep peeling off the tissue. And this works very well in any of these very advanced keratoconic patients where you can't do a big bubble technique. But what I wanted to highlight in the next couple of slides is, while you may have a little bit of residual stroma, mild folds in the interface, this usually goes away with time and it integrates. And you can see here, there might be slight differences from the center to the mid periphery despite whatever care that you've taken, but this compacts over time. And as you can see, it is almost gone after a month's time from the initial graft, and that residual is gone. And you can achieve good topographic results, good BCVA, even after these dissections. So just a quick couple of slides on big bubble versus manual. Big bubble gives us faster visual recovery and greater consistency in our results. But studies have shown that manual, while there is a slightly slower recovery, if the residual tissue is less than 70 microns, the final long-term results are comparable to that of big bubble in terms of visual acuity. PK versus DALK. Rather than leaving the patient with a very irregular bed with a thin center and a thick mid periphery where the quality of vision, the interface haze is very high, you do very well to even convert them to a PK in case you're not able to achieve a smooth layer. Yes, we would try to attempt a DALK first, but even with PK, these patients have excellent outcomes and the survival rates are very, very good. So we always try to attempt a DALK with irregular bed. Don't have hesitation to convert to a PK, even in the late post-operative period. Not immediately, but let's say 2 to 3 years down the line, still the patient's interface is not modulating. A PK will give them excellent results.